Hello and welcome everyone. I'm going to get started. I'm sure folks will continue to join us as we um, get going here, but we're so glad to have you with us on today's webinar, which is being co-sponsored by Pregnancy Justice, Vital Strategies, and the Institute for Innovation and Prosecution at John Jay College. My name is Kate Boulton, and I'm a health justice attorney who works as a senior legal technical advisor in the Vital Strategies Overdose Prevention Program. In that capacity, I support various legal and policy efforts and projects to advance a harm reduction approach to substance use and to reduce overdose. Historically, I've been fortunate enough to work on a number of our initiatives projects targeting the intersection between drug policy and maternal health. I'll be moderating today's webinar, where we'll be introducing you to this exciting new resource, Interrupting Punitive Responses to Substance Use and Pregnancy, which was launched just last week. A few housekeeping items before we get into it. We would like to record this webinar so that it can be made available as a continuing resource. Attendees will be able to submit questions through the Q&A feature, which we will plan to address during the last 15 minutes or so of today's webinar. I'm hoping our tech support could start recording now.
It's automatically recording.
Fantastic, thank you. Okay, so I'm really grateful for the fantastic panelists that we have today, including Dana Sussman, Senior Vice President at Pregnancy Justice, Dr. Jamila Perritt, President and CEO of Physicians for Reproductive Health, and Kim Foxx, former Cook County State's Attorney. Fortunately, our fourth panelist, Naja Morris-Frazier, Director of the Lead Support Bureau, was unable to make it today. You'll learn more about the work and unique perspective of each of our panelists as we get into the questions. But first, I want to offer a bit of background on the origins of this collaboration between Pregnancy Justice and Vital Strategies to create this new tool, and a little bit of what you can expect to find in the resource. So we first began conceptualizing this project about 2 years ago in the context of increasingly punitive responses to substance use in pregnancy, and specifically pregnancy criminalization, which refers to arrest, prosecution, or imprisonment based on allegations related to someone's pregnancy, pregnancy loss, or birth. It can also refer to the application of harsher or different penalties on someone for being pregnant, even if the underlying offense or charge has no connection to their pregnancy. Pregnancy criminalization on the basis of alleged substance use, which of course is the target of this tool and this collaboration, can really be understood as the confluence of broader attacks on reproductive autonomy, including the Dobbs decision in 2022 and the aftermath that we continue to see from that, alongside the widespread stigma and discrimination that we continue to see against people who use drugs specifically. Our aim with this tool was to put forward concrete and practical strategies for criminal legal practitioners to adopt a different approach to substance use in pregnancy. So instead of the prevailing standard of surveilling people, criminalizing people, or otherwise punishing pregnant people who use drugs, the toolkit really aims to offer a path for criminal legal practitioners to adopt alternative approaches that are grounded in public health and community well-being. The resource itself, which is linked in the chat, and we'll continue to throw it in the chat as we progress, is structured into an overview that describes what pregnancy criminalization is, as well as its harmful consequences for maternal, fetal, and infant health, and the case for a public health approach to substance use in the context of pregnancy. The tool is then broken out into discrete sections that target criminal legal practitioners across different domains of the criminal legal system, including law enforcement, probation officers, prosecutors, and judges, with the idea being that these practitioners each have unique opportunities to interrupt punitive responses to substance use in pregnancy at each stage of someone's movement through that system. There are tailored recommendations in each of the sections, but also some common themes that I want to touch on here that go to best practices and considerations across the board. First, ensuring compassionate interaction with pregnant people who use drugs is essential, including adoption of trauma-informed practices to the extent that's possible. This is especially important in the context of pregnancy loss or other traumatic birthing experiences. And we know that fear of judgment and punishment actually function to drive people away from systems of support and care, ultimately contributing to poorer outcomes. Secondly, practitioners should leverage their discretion at each stage of the criminal legal system to challenge punitive responses to substance use in pregnancy. And this includes numerous decision points that we can't cover comprehensively here, but in the toolkit, we talk about the extent of a criminal investigation, requesting an arrest warrant, pursuing prosecution, establishing supervision conditions and probation, and setting bonds. These are all potential opportunities to do things differently in order to promote the health and autonomy of pregnant people who use drugs. Third, criminal legal practitioners should avoid assumptions and stereotypes about substance use during pregnancy. For instance, the assumption that any substance use necessarily has detrimental effects on a pregnancy, or the belief that someone who uses drugs cannot parent safely. These knee-jerk responses are not reflective of the evidence and more often can be indicative of longstanding stigma against pregnant people who use drugs, particularly pregnant people of color. Fourth, criminal legal practitioners can educate themselves about the basics of substance use disorder, including evidence-based treatment options and other effective strategies, such as linkage to community-based harm reduction services. Criminal legal practitioners can also advocate for a response to substance use in pregnancy that is spearheaded by qualified health professionals providing evidence-based voluntary health and social services. In other words, law enforcement, judges, probation, and prosecutors aren't clinicians and shouldn't try to take that on as part of their role in addressing these issues. Finally, and relatedly, criminal legal practitioners are encouraged to learn about and be aware of community resources, services, and providers, including harm reduction resources that can support pregnant individuals with substance use issues. Big picture, the toolkit really calls for a recognition that the criminal legal system is fundamentally not where we should be addressing issues related to substance use in pregnancy. It's, of course, important to strategize about how can we reduce the harms and improve practices within this system, because we don't want to leave people behind who are already involved or at risk of being involved in these systems. But our ultimate goal is to move toward a health-driven response that centers the well-being and autonomy of pregnant people who use drugs, and to do that outside the criminal legal system. I'm sure our panelists will expand on some of these themes in their remarks. So I just want to say a few final words about the process of developing this resource. Drafting this tool was supported by a multidisciplinary advisory board composed of individuals with a range of professional and lived experiences. Dr. Perritt, who you'll be hearing from on this webinar, was a member of the advisory board. The tool also benefited from the insights of several external reviewers, including Nadja Morse-Frazier, who unfortunately wasn't able to join us today as a planned panelist, but you can find more detail on the advisory board and the external reviewers on pages 18 and 19 of the toolkit, which we'll continue to put in the chat. And you can also find some supplemental videos at that link to the Pregnancy Justice website, and those feature insights from a prosecutor, a person with lived experience, and a clinician. Two of the folks you'll see in that video were also members of the advisory board for this project. And so now we can move into the interesting part of today's discussion. I'll be posing questions to individual panelists, but encourage folks to riff off of one another's insights because that always makes for a richer discussion. And if each of you could say just a couple words about your affiliation and role when I come to you, that would be fantastic. And so Dana, I am going to start with you. Can you talk more about the impetus for this project and how it responds to the landscape that you're seeing in the work of pregnancy justice? And also what's new or different about this resource?
Great. Thank you so much, Kate. I'm Dana Sussman. I'm Senior Vice President at Pregnancy Justice, and I've been working with the team on the toolkit for over a year at this point, I think. And at Pregnancy Justice, we defend people who are charged with crimes in connection with their pregnancies or pregnancy outcomes, whether they experience a pregnancy loss, have an abortion, or have a healthy birth. And one of the things that has remained consistent over the 25 years the organization has been around is that the majority of people who face charges in connection with their pregnancies are people who use drugs. And this has its roots in the war on drugs of the 70s and 80s, primarily targeting Black women for allegedly using crack cocaine during their pregnancies. Those were some of the first people charged with crimes in connection with their pregnancies, and they were often charged with child abuse or child neglect for exposing their fetus to substance use in utero. And that began in the 80s, and we can trace it back to what is now a debunked or a very criticized article that talked about this so-called crack baby epidemic that we would be seeing and laying the blame at the feet of primarily Black mothers. We are still dealing with the ripple effect of that singular article, that singular, very small study. And the shape and the form of this has evolved over time. But again, even in a post-obs landscape where we are seeing criminal system involvement or criminal legal involvement in pregnancy in all sorts of sort of what people are believed to be new ways, this continues to be the primary way that people become embroiled in the criminal legal system in connection with their pregnancies. So we released a report last September looking at preliminarily the first year after the Dobbs decision to see who was facing criminal charges in connection with their pregnancies in that first post-Dobbs year. And what we saw was it was very similar to the pre-Dobbs world in that the majority of cases we identified 210, which I will give you all the caveats is an undercount. It's really hard to find this information. We're still finding these cases, and we will be continually updating the data on our website. But we found 210 cases in that first year, and 203 of them had allegations of substance use in pregnancy. Now, not all of them were charged in connection with substance use, but that is often the entry point for criminal investigation and criminal charges. We saw that before the Dobbs decision, and we continue to see that today. Now, there could be other allegations that come into play about what we hear periodically: lack of prenatal care, abortion contemplation being used as evidence against them, but we often see sort of the door opening to investigation because of substance use. And of course, we'll get into why criminalizing or using the lack of prenatal care as any evidence against someone as, obviously something that we take is deeply problematic for multiple reasons, including the fact that people who use substances during pregnancy may avoid prenatal care because of these very real fears. And so it becomes this sort of repeating cycle. So the landscape has not shifted dramatically in the context of substance use in pregnancy because of the Dobbs decision, for the very reason that this has been happening for decades. But we are seeing more and more cases and are documenting them more robustly in this post-Dobbs world. I think the second part of your question around why this is unique, we are not often, as folks who represent people on these cases in a defensive posture. We don't always have the opportunity to speak to law enforcement. We don't always have the opportunity to speak to all the different all the different players, all the different, the full ecosystem of law enforcement. And so this partnership with Vital Strategies and with our advisory board really allowed us to provide information that we think it could be useful as different offices consider different alternative approaches. Um, we um, we have had conversations with prosecutors around the country about this, and some really wanted to hear from medical experts. They wanted to understand why arresting someone was not an intervention that was useful or helpful or safe for people who have substance use disorder while pregnant, or dealing with substance use disorder and pregnancy at the same time. And we also have spoken to prosecutors, and one of them is featured in the videos that Kate referred to, who reviewed their own internal policies after engaging with us and our partners, and determined that they actually were charging pregnant folks who had substance use disorder with crimes, and decided to stop after kind of engaging in some of this conversation. So this is a unique opportunity for us to provide as much expert um, information, up-to-date information, and to hear from law enforcement themselves who have engaged in these questions, to offer alternative approaches. So that's sort of what's new about this partnership.
Thanks so much. And I just wanted to add, a part of the impetus for Vital Strategies and in those early discussions was the growing role of overdose as a leading cause of maternal morbidity and mortality. So, as we saw dramatic increases in overdose fatalities nationally in the teens and early 20s, that was also happening among pregnant folks. And I can throw some analyses in the chat documenting that. But this too is intended to promote alternative responses that are less likely to increase folks' vulnerability, and to really embrace those health-centered responses. And so turning to you once more, Dana, I want to ask about some public opinion polling that was commissioned by Pregnancy Justice and National Women's Law Center, which assessed voter attitudes towards pregnancy criminalization. And we'd love to hear some of the notable findings from that polling, and if any of them stood out to you or surprised you.
Yeah, so we refer to this in the toolkit, but I will also drop a link directly to the research in the chat. But we originally wanted to investigate likely 2026 voters across demographic groups, for their understanding of what we call, quote, fetal personhood, which is really this conversion of laws that apply broadly to the context of pregnancy through kind of redefining person to include embryo, fetus, or fertilized egg. And what we learned from this research is that most Americans have no idea what fetal personhood means. So we should all stop using that phrase and really explain what it means very plainly. But in addition, we also wanted to know what the public's opinion was of prosecuting or criminalizing substance use in pregnancy, because that we thought in sort of the work that we do, that would be a really hard thing for to sort of disavow the public of, in particular because that sort of, quote, crack baby mythology has really stuck around. We're talking like my entire lifetime, decades and decades, and we're still kind of dealing with it. But what we were surprised to find is that overwhelmingly voters do not think a criminal approach to substance use in pregnancy is appropriate. And this might be because we have started to see a more humane public health oriented shift in substance use disorder as a result of the opioid epidemic and the way that it has permeated communities across the country, and sort of like the national response to that. And so we think that we're starting to see a real shift in people's opinions surrounding substance use disorder broadly, and we actually think it's having an impact on people's views of substance use disorder and pregnancy. So over 80% of likely 2026 voters um, do not want a criminal response to pregnancy and substance use, and they really want a public health oriented response. And if I just want to pull out a couple specifics, because we do have some suggested messaging too for anyone who might need it or is interested, but what people saw was that the likelihood that confidential information that pregnant people share with their doctors about substance use disorder, that would be shared with police, and nearly 70% of people oppose it. That pregnant people who seek treatment for substance use disorder would be criminally charged with child endangerment or neglect. Nearly 70% of people oppose that. And the idea that every pregnant person would be drug tested when they give birth, and if the drug test is positive, the test would be shared with police and used to charge a pregnant person. 60% of people oppose that. And so if people are in elected positions, or they're in positions that, they are engaging with their constituents, this is, I hope, helpful information to have. And that the messaging that resonated the most strongly is that people should be able to seek care without fear of being punished by law enforcement. Nearly 9 in 10 voters agree that it's important for pregnant people to be able to seek care, and to not worry about being criminalized, and that the specter of criminalization, the worry about criminalization, turns people away from getting the care that they need. And people really understood that. And almost everyone, knows someone with substance use disorder, knows that that getting care in an accessible way, in a non-judgmental way, is essential. And that's no different for pregnant people. So again, I'll drop the link to the longer survey out results and messaging in the chat for folks who might be interested in diving in further. It's also referenced in the toolkit. But that was actually very pleasantly surprising for us. We did not expect to get such a sort of a robust support for a public health approach. And we also watched as the DA, who changed her policy in Hennepin County, Minnesota, and dropped a bunch of charges, that there was, we kind of monitor the media around that, and that seemingly was received very positively. We haven't heard a vocal critique of that. So we were very glad to see that, and hope that others might consider the same, and know that generally the public is behind that kind of approach.
Thanks. That's quite heartening to hear. And yeah, really encourage folks to explore those findings and think about how they can be leveraged in different messaging efforts. So I'm going to turn to Dr. Perritt now. And part of what this new resource tries to do is challenge prevailing assumptions about substance use in pregnancy. And I'm hoping you could talk about what some of those assumptions and misconceptions are, and how they've shown up in your work as a clinician.
Sure. Thanks so much, Kate, for that question. And thank you to Pregnancy Justice and all the folks who've really been so deeply invested in this work. As you heard, my name is Dr. Jamila Perritt. I use she, her pronouns. I'm a board certified OBGYN and the president and CEO of Physicians for Reproductive Health. PRH, as we call ourselves, is really a network of doctors organizing and mobilizing other medical providers to advance access to comprehensive reproductive health care for the communities that we serve. A lot of the work that we do really sits in the policy and legislative space, but also around strategic communication. And largely, really, a lot of our focus is on provider training, right? How do we train doctors to do work outside of their clinical space? How do they understand the impact and the influence of all of the context of the lives of the patients that they care for, how that shapes the way they think about care, the way they receive care, and whether or not they seek care in the first place. We understand really deeply that doctors hold a lot of power and privilege. And as we talk a little bit more today about pregnancy tests, drug tests during pregnancy, and criminalization of pregnancy outcomes more broadly, what you'll find is that doctors are often that entry point into the criminal legal system for the patients that we care for. We know that doctors have power and privilege, and the question is, can we leverage that power? Can we shift that privilege, understand what it is, and how we can use that privilege to improve outcomes for the folks that we care for. We really began our work around pregnancy criminalization a number of years ago through our relationship with other organizations who were doing so much of this work. But the ties between the medical system and the carceral system run deep and have long existed. And we understood that when we began engaging in this work, that we had a pretty big fight ahead of us. Just even thinking back to the criminalization of abortion in the mid 1800s, the demonization of Black midwives in the South in the early 1900s, and Dana talked about Black moms in the 80s and the so-called crack baby epidemic that ultimately led to mass incarceration, punishment, child separation. So these ties really run deep. And the question for us was, well, what can we do to help our doctors, the healthcare providers in our network understand that substance use disorder, not substance use period, but substance use disorder is a medical issue and not one for criminal intervention. And so that is really how we entered this space in the work. When you talk about, some of the assumptions and misconceptions that folks who use substances during pregnancy, and I'm also going to include those who use them while parenting too, because it's also often part and parcel of the same community. Folks believe that people who use substances during pregnancy or while parenting are careless, right? They just don't care about their baby. They don't care about the pregnancy. They don't care about their health. Believe that they're weak, right? They can't make responsible choices for themselves. And most importantly, folks believe that those who use substances, their behavior needs to be controlled. Right. And so when we look at the cases that Dana talked about, the investigations that Pregnancy Justice had done, the folks who are incarcerated, often that framing is to protect them from themselves. Right. This idea that you can't do it, the state needs to step in. And for those who are parenting, the idea that drug use is a litmus test for parenting in general. If you're using drugs, you must not be a good parent. And so for us, we really want to do a number of things when we think about how we engage with clinicians around this issue. One, to really understand why doctors are reporting, why are healthcare providers, social workers, nurses, why are they calling law enforcement on their patients in the first place? And there's a good amount of research that shows that healthcare providers are doing it for the most part because they think it's helpful. They think that it will provide this individual with resources. And then there's also this idea in the way that patriarchy has always shown up in medical care, this idea of saving the baby, saving the pregnant person, saving the parent, right? These are all things that are going to be helpful. And what we know simply is that that's just not true. There is no support in the system. The carceral system is not designed to provide care. And we only need to look at the healthcare that is provided within carceral institutions to see that there is no way that care and punishment should ever overlap. And so in those places where that occurs, the care is either non-existent, it's poor, or really, really difficult to obtain. But doctors and healthcare providers, they think they're helping, right? Or at least they say. I think that of course there are going to be some folks who are doing so because of ideas around punishment and deservedness and who should parent and who shouldn't. But for the most part, this is the response that we get. So what does it look like, right? Because when you talked a bit about how folks don't really know what this phrase personhood means. The same thing came for us, or the same situation showed up for us when we began talking with doctors about criminalization in care. They didn't know what criminalization was, despite the fact that all of us have engaged in criminalization in care spaces because we are healthcare providers, either by choice or by force, but they didn't understand what that term means. So what does it look like when we're talking about criminalization in places of care? What we're talking about are folks that are showing up for care and ultimately have law enforcement or the state called on them to manage, again, their behavior. And I want to just broaden out a bit too when we think about who counts as law enforcement, right? So it is sometimes the police that are physically in the hospital or calling the police on your patients. Other times it's a passway. And so we learned this in our conversations with healthcare providers, especially, that they'll call a social worker, and the social worker makes a report to the state. All of that to me is ultimately engaging with law enforcement. And so whether we're calling law enforcement or the state for somebody who's experienced a pregnancy loss when they're showing up for care, or they're suspected of self-managing their own abortion, and the state is called. We see this with unconsented drug testing during care. So folks are showing up to get care and somebody's a little suspicious, like, I don't know, they look like they may be using, and send a battery of tests for sure, and are not clearly giving informed consent to the individual that they're doing biological testing on. And I would also offer that some places have incorporated a universal testing protocol. So everyone who comes into that space is tested. That is the same. It does not, again, offer an opportunity to really discuss what's going on from a medical standpoint and to provide the support that people need. So whether we're doing this risk-based testing, we call it risk-based, or I call it suspicion-based testing, or universal testing, the outcome is the same. It triggers investigations for the people that we care for. And the other part about it, and when we think about the risk-based testing in particular, it is really based on the suspicion of the clinician, whether or not they suspect you are doing something, because people use substances all the time, but everyone isn't diverted to law enforcement. Everyone, it doesn't have social services calling them. Everyone doesn't have their children taken from them. So this suspicion cannot be disassociated from the way discrimination and racism in particular plays out in places of care. So folks that are living in poverty, Black and brown and indigenous folks for sure. If you've had a previous positive urine pregnancy test, whether it was during this pregnancy or last pregnancy or not during pregnancy at all, that's going to trigger a test, right? And these triggers, right, or lack of prenatal care, I think Dana mentioned that too, or poor prenatal care, right? So there are recommendations around the appropriate number of prenatal visits an individual is supposed to have. If you fall below that threshold, automatically that triggers, because again, it goes back to these beliefs that these people don't care about their pregnancy, that this is not important. And as a result, they do not deserve to parent. And that is what the bottom line is when we talk about what's happening in criminalization during pregnancy. The deeply held belief that some people do not deserve to parent. So I think I'll stop there. Yeah.
Thank you. Thank you. Really powerful to consider it as a sort of larger and more sprawling
It is.
systemic response. So
And
I
I think,
appreciate that.
and the reason why I think it's important to do that, I know that we're talking about criminalization during pregnancy, but you cannot criminalize one behavior and not have that impact the rest of an individual's life. Because what this is really about is not the behavior at all. This is an attempt to criminalize the individual, to criminalize entire communities. So it doesn't matter the behavior you engaged in. We are criminalizing people because they're pregnant, because they're not pregnant, because they're parenting, because they're not parenting, because all of our ideas of what it means to carry a pregnancy to term, what it means to parent a child, to build your family, are grounded in very narrow ideas that privilege those that have the most resources, that fit into this box, right? We're talking about wealthy people, resource folks, middle-class folks, and almost always white cis women. If you don't fall into that category, the likelihood that you will be criminalized when you're seeking care is very high. This is a tricky thing for doctors to really wrap our minds around, because doctors are trained to believe that we are inherently good, that we wouldn't be doing anything that would cause harm to a patient. So really confronting the fact that when you're engaging in mandatory reporting practices, when you're calling CPS or whatever acronym you use in your own state, when you're calling the police on patients or partners or family members, those things cause harm. And really grappling with that is an important factor, because again, healthcare providers are one of the most likely people to report folks when they're seeking care. And this includes doctors, nurses, social workers, the entire gamut of folks that are in spaces of care. And instead of being able to get care, you show up and you're criminalized.
Yeah, and it's because of a lot of those harmful consequences that we see leading medical and scientific authorities, at least in terms of sort of those formal, statements of principle and position and guidance, opposing pregnancy criminalization. So like the American Medical Association, American Society of Addiction Medicine, American College of Obstetricians and Gynecologists, because, we see that when folks fear that surveillance and that criminalization, then the natural response is to avoid care altogether. And so
That's exactly right. That's exactly right. And I want to just be really clear that this isn't something that these statements of policy or position were not happenstance. They weren't coincidental because some folks there had like some big epiphany about the fact that incarcerating pregnant and parenting people causes harm. It was work and organizing of healthcare providers that were involved, that were members of these organizations. And so when we think about what strategies look like to push back on the criminalization of people in care spaces, it always comes back to organizing. And so we worked with the doctors in our network, with the doctors that that provide obstetric care, prenatal care, infant and child care, and really organize them to push their professional organizations to come out with these statements. Now, is a statement necessarily going to change the way that everybody moves? No, it's not. It is a start, right? Because what these statements of principle, what these statements of policy do is that they shape clinical practice. And they also provide support for people who have been criminalized. The other work that we've done at PRH is really talking with folks that are on the ground who are experiencing, directly impacted by the criminalization of their pregnancy outcomes or their parenting decisions, and ask them what would be helpful, what would be useful, right? And so we partnered with organizations that have been doing this work much, much longer than we have at PRH. So folks like Interrupting Criminalization, or the folks at the Beyond Do No Harm Network, Pregnancy Justice, If, When, How, for sure, and really thought about, well, what would be useful? And one of the things that they talked with us about certainly are these statements of policies, because then they can use those statements to advocate in their local jurisdictions to remove either these legislative, if it's an actual law that's on the books, to remove them from the books, or within their institution to reverse and to shift those policies, right? So to be able to point to something and say, well, look, the American College of OBGYN said we shouldn't be doing this, said that drug testing is not a litmus test. Drug use is not a litmus test for parenting. We should really stop moving this way, right? So really being able to move in that direction. And ultimately the goal, at least for me, and maybe I don't think that maybe everyone is there yet, but my ultimate goal is abolition. It is the dismantling of the prison industrial complex, and a dismantling of the idea that that is something that is actually useful, that people should be punished and incarcerated when you disagree with their behavior.
Mhm. Thank you so much. I'm going to turn now to Kim, and I'm excited to come to you as someone with applied insights from your work as a state's attorney. I'd love to hear, what do you say to prosecutors who argue that a punitive response is necessary because there are no other options, or that it is an appropriate mechanism or strategy to try and get someone into care?
Thank you for that, Kate, and thank you all for this riveting conversation. It's been a pleasure listening. I really don't think I have too much more to add because you hit it. But I do appreciate coming after Dr. Perritt, because she really set the foundation quite well. I am Kim Foxx. I was the former Cook County State's Attorney here in Cook County, which encompasses Chicago and its surrounding suburbs. The State's Attorney's Office was the second largest prosecutor's office in the country. And I had the privilege of serving for 2 terms over 8 years. But more significantly for this conversation, I was a line assistant prosecutor for 12 years in that office, a significant portion in our child protection unit. And so for a lot of our prosecutors who are on this call, who are hearing the word criminalization and thinking solely on oh, we rarely prosecuted or criminally prosecuted people for drug use, where we saw the largest significant population were in those child protection cases, which is another form of criminalization, even if we are not talking about incarceration. In fact, the harms are just as significant when you are able to take a child away from their parent, when homes are broken up. We talk about taking people's liberty, that I don't know what else could be more harmful than taking a child from a parent as a result of this. And a significant portion, when I was a line assistant, of the cases that we saw that came through the child protection work came through, as Dr. Perritt so eloquently described, testing practices at hospitals, a call to a social worker, and the social worker calling Child Protective Services, and then a referral to our office to assess whether or not we would be intervening on behalf of the state. Now, I should say, again, coming in this part of the panel, the experts that prosecutors, lawyers rely on are doctors. We get statute books that lay out in the statute what the crimes are, what the things that we should consider, but the expertise about this comes from the medical profession. And so I cannot overstate, and I will repeat because it's necessary, that this notion of criminalization, this notion of harm that the parent is doing to the child had been dictated through the science that was laid out previously around, the crack baby epidemic or the passing of these drugs. And the response from law enforcement and from prosecutors was, oh, we have been told that a harm is being inflicted upon a child. And we can talk about personhood in a moment, but way back when, it's a harm is being inflicted. And as law enforcement, our job is to ensure that people are not inflicting harm upon others. And so if you were not in utero and I did something to harm you, we had a mechanism for that, to deal with that, right? We can arrest you and incarcerate you. But now we're talking about, someone's body and a growing life within a body, and the intersection with the healthcare issue of substance use disorder. This is a healthcare issue. And the reality is we are slowly catching up to that reality. Dana, I'm encouraged by the data that you provided a bit earlier around how we perceive substance abuse disorder now. I would be remiss, and I'm looking at you, Dr. Perritt, to say the thing that's the thing, which is when we were talking about the war on drugs and we were talking about the crack epidemic, it was highly racialized. And the response as a result, when we're dealing with these issues around racial justice, is over punitiveness, over incarceration, over surveillance. That when we saw an increase in death related to substance use disorder, and we saw that increase across all bounds. So not just urban centers, but rural centers and the like, suburban centers. Then there was this, my gosh, we should do something. And the reality is, and how we talk about it. Now, we're not talking punitive, we're now talking public health. And it had always been a public health issue. And so this evolution to where we're talking about public health and substance use is not a real evolution. We had institutions, we had doctors and hospitals and the like that were treating these as public health matters all along, particularly in areas where we weren't seeing high concentrations of Black and brown women who needed the care. And I say this because when we looked at, as a line assistant, where the calls were coming for who was being tested, it was our public hospital, Cook County Hospital, which is one of the third largest, it is the third largest health and hospital system in the country, but it is the public hospital. And so who is using the public hospital? It is largely people of color, largely people who are below the poverty line. And so and people who had issues of substance use. So you had a pool, you had a pot. And what we were seeing, and we knew that drug use is fairly consistent across demographics, a large concentration of cases that came to us from Cook County Hospital, very few that came from, say, Northwestern Memorial, or very few that came from our, Lutheran General, these other hospitals who had the same ability to do the testing and the like. But again, the suspicions are different depending on where you live. So I say all of that to say that as a line assistant, as a prosecutor, when you get these cases, you're told this is what we have. This is the statute. The doctors have told us that this has happened. And this is one of the very easy cases to prosecute on the line. It's very easy. All you need to prove this case is the test. So the question is not so much, how we do it. The question is, should we do it? And so in answering this, particularly for prosecutors, because again, there's a lot of medical information alike who are going to say, but that's my job. They've given me these things. How do I respond? And the thing that I always often went back to with my line assistance is this in the interest of safety, public safety, or prosecuting this case, taking this child, doing this? Is this in the interest of greater public safety? And oftentimes we know in these instances, they are not. It is about trying to change behavior. And the issue is that that's not our role. Our job as prosecutors, as ministers of justice, in terms of keeping our community safe and being fair and equitable, it's not about changing behavior. The system, the adversarial system of the criminal legal system is, you've done something and now we're holding you accountable for it. Our responses are not about accountability. We can't force people to go to treatment by taking their children from them. We are doing harm in the interest of saying that we are doing help. And so, what do I say to people, or what I said to my team when I worked at the office is, what is our ultimate goal? If care is our ultimate goal, then we are not the place for care. We're not designed for care. We do know the community-based organizations and other networks that provide that level of care. We don't have to be the intermediary to do that. As the patriarchal narrative goes, we like to use the fist of, the system to be able to encourage you to do something, which defies what we know about substance use disorder. It defies that kind of, we need the carrot and a stick. If you are struggling with substance use disorder, you could care less about your stick. You are struggling. That is what the struggle is. And so what I say to folks is, really have to evaluate what are the goals that you are trying to achieve here. And are those goals offset by the harms that you are imposing by your policy? And what I'll say about that is this very quickly. In Illinois, we had a statute that says, we can take a child into care if they were born positive with a substance, and we could terminate a parent's rights, their parental rights to their child within 9 months to 12 months if that parent continues to use substance use disorder. The thing that keeps me up at night, and I'm 7 months out of the job, thinking about the decisions that were made 10, 15 years ago when I was on the line, are how many legal orphans we created by taking children and terminating parental rights because the family did not adhere to the care that we said that we needed them to have to be able to parent, because ultimately that's what we said we cared about. And instead we created legal orphans by terminating parental rights because we put arbitrary numbers on or arbitrary deadlines on when people should kick their habits. And so it is a complicated mix when you are told, well, I'm just responding to what has been given to me. And I think leadership in these offices, particularly around these issues, have to be bold enough to say that this is not what our office was intended to do, and that in doing these practices, we are actually causing more harm. If you are causing harm with your policy, then you must revisit the policy. And as a line assistant, your responsibility and obligation, when you have a case that comes across your desk that you say, listen, I don't believe that ethically this is something we should do, is to take it up to your supervisors. But starting with the notion that this is easy work to do, it's very easy. It's been set up to do that, to interrogate the harm that comes from having done that.
Yeah, I think that's, sorry, go ahead, Dana. Go ahead.
If I was just going to jump in, I so appreciate you saying, Kim, the piece about these cases being sort of easy to prosecute, sort of like low-hanging fruit, for lack of a better phrase. And our research shows that. So in the majority of the cases that were prosecuted in that first year post-obs, they were under statutes that don't require any showing of harm. It's simply by virtue of a positive tox. And we can get into the flaws in the science around sort of the non-confirmatory testing and the sort of dipstick testing and all of that. But even just that alone is enough to prove exposure to some risk of harm, which is all you need for a neglect charge in some places. So it was truly no showing was required for any harm at all, just mere exposure to some risk of harm, and that positive tox is often enough. And so that's the decision to sort of take those cases. We could be a whole nother conversation, but also it just shows the sort of that exactly what you described is sort of that's all you need.
Yeah, and that's where prosecutorial discretion is incredibly important, right? Because yes, it is easy, and we can make the call from the beginning of, yes, I have the elements here. Is this how I should be using my power and resources? Because what you'll hear is, but my hands are tied. Like that is enough. If the hospital sends over that positive tox screen, none of this other stuff matters. You've now checked the box. And the question that a line assistant, or if they're watching on this, are saying to me, well, what do I do with that? I have it. I am obligated to prosecute this. And what I would suggest is that you are not obligated to prosecute that we have mechanisms in place across the board where we can deflect people out of the system relatively easily if we choose to. And what I do appreciate about this conversation is when Dr. Perritt is talking about organizing, it does matter when these groups, when obstetrics and gynecologists come together and say, hey, this is not in the interest of good. It helps us. We need the help to be able to make the case that we are not just allowing children to be harmed, because that's what we're being told. We don't have the intricate knowledge that you all have. We are, I dare not say ignorant, but it is a lot of indoctrination that has gone into place around substance use disorder by a pregnant parent, that we too, much like the doctors who want to do good, have been told that this is bad. And we don't have enough information that's been presented to prosecutors' offices like you did in Hennepin County to be able to make the argument that actually what we are doing is bad as well. And that work is critically important.
Yeah. And I would offer, because so much of it does come down to prosecutorial discretion, what the work that we're doing is to tell folks, don't send it. Don't send the test. And then it's not up to anybody's discretion of whether or not this person is going to be jailed, whether or not the person will be investigated, the child will be taken. Very rarely does the use of a substance change your medical management at any point. It's almost never. Right? If somebody comes in labor, you're not going to manage them differently because they smoked marijuana or, used cocaine before they got there. You're not going to change your management if somebody's having an emergency. This idea that you need this information. We don't send liver function tests when you break your toe, because it's not relevant to the care that you need. And so really re-emphasizing with healthcare providers to only send relevant information, because this information will be used against the individual. If you feel like you need to send that information, have a conversation with the person. Listen, we need to send this. One, we need your consent. We would like your consent, because this consent is a process. And what that means is the person actually gets to decline. And then you don't get to go on the back end and take a urine from the baby without the parent's consent, right? That is also a violation of the human rights of the folks that are seeking care. So really understanding what you're doing when you just even send that test in the first place, and making sure that you're communicating to the person who you suspect of doing something, what the possible outcomes will be if that test is positive. The research has clearly shown that people are more likely to disclose substance use when they're given the information, as opposed to the trickery that folks engage in to collect data without consent, and biological testing in particular. I saw the question in the chat, Kate, about the whether or not which states or how many states, I think, require medical providers by law to report substance use by pregnant people. So it's a really tricky question to answer for a couple of reasons. Because one, the laws are all over the place in states. There are only, I think, 3 states, and Dana or Kim, please correct me with that number. There are only a handful of states that actually mandate it, right? But there are a number of states that mandate reporting. But again, nobody's mandating testing. Nobody is mandating testing. So it doesn't matter what the state says about reporting if you're not actually doing the test in the first place, right? But their laws are all over the place. Some states mandate that providers have to report suspicion of using substances during pregnancy. How can you suspect somebody is using substances during pregnancy? And again, not to belabor this point, there is a clear difference between substance use disorder and simple substance use. And we're not testing and reporting for everything. We're not testing for folks who are reporting for people who are using alcohol during pregnancy. We're not reporting people who are smoking cigarettes during pregnancy. We are not screening and testing and reporting for every single thing. So that really, again, goes back to the idea about who gets to determine who should be pregnant and who should parent. And we have decided collectively that folks who are poor, folks who have fewer resources than we think that they should be engaging in, right? Folks who are using substances, none of these people deserve to have their children, because you must believe that if you actually send a test that can result in taking their children from them, you must believe that they don't deserve it. The conflation of poverty and neglect is really high in these family separation cases, right? And so if the issue is poverty and not neglect because of whatever reason, right? Then what they need is resources. What they need is support, right? And there is no support in the system.
Yeah, thank you for that. And I see an attendee from If When How has shared a resource that organization put together around this question, so we can try and circulate that as well. We're coming to the top of the hour, so I just want to thank all of the panelists. This is such a helpful discussion, really laying the foundation on what the toolkit is, the goals of the toolkit, and why it's so essential that we shift away from a punitive response to substance use in pregnancy. Dana, can you put up the slide with our contact?
Yes, hold on one sec.
Yeah, so I know we may not have gotten to all of the questions that folks had, so I just want to encourage you to contact me or Dana if you want to have a follow-up discussion or had follow-up questions about the tool, how to use the tool. We hope this was an informative discussion, and would appreciate if you can disseminate and amplify the resource within your networks, with your colleagues. As I said at the top, there should be a recording of this webinar made available in the near term, which we hope will be a continuing resource. But thank you again to all of the panelists and for your discussion today. Thanks so much.
Thanks, everyone.
Take care.